Thank you very much and good evening, everyone. It's a real privilege to be here. And I realize that there are a lot of exciting things all going on at once. But I'm going to be a very bossy moderator and ask that if people would like to have conversations, maybe they could take them outside of the room. I realize that we stand between you and the reception. So I'd really like to get going very quickly. So if everyone could either take their seats or move outside, please, that would be wonderful. Before we get started, there is a poll in your app. So if you're using the app, please do look at that poll and we'll come back to it. I would really love to run this session in a very interactive way. We have a few short questions for the panelists. So I'm hoping we'll take the first 15 minutes or so to ask them some of those questions. But I'm hoping to then open it up to the audience and take several questions in one go so that we can have some audience engagement. I think my colleague Coulter gave you an initial high-level overview of what this panel is really about. But many of you may be aware that the government of India has invested significantly in the past 5 to 6 years in rolling out sort of Ayushman Bharat, which has several components to it. But the piece that we're going to focus on tonight is really the piece about strengthening comprehensive primary health care across India. And I think this panel flows very nicely on the previous one, because part of what the government was trying to do with this rollout of primary health care was really strengthen services for non-communicable diseases at the sort of frontline level. And so there has been very significant investments in Ayushman Bharat. We've had sort of 160,000 health and wellness centers established across India. There's been a whole new cadre of health workers, CHOs established, who've been trained to sort of treat NCDs. But my sense is that some of the low-hanging fruit around this agenda has been addressed. And what we really wanted to focus on this evening was the journey so far and the unfinished business. I'll also introduce to you 3 distinguished panelists. I'm so delighted that each of them could join. I'm not going to reintroduce them, but I'm going to kick off by asking Dr. Rajani Bed to reflect a little bit on the journey so far. What does she think has been, what do you think, Rajani, have been the real accomplishments in terms of this ambitious set of reforms that the government has embarked upon? And also, what do you see as the most critical next steps in terms of things for the government to address? Over to you.
Okay. Thank you, Sara. And I'd like to thank the organizers for inviting me to be on this panel. Since independence, India has actually implemented a form of primary health care we used to call selective primary health care, largely focused on immunization, maternal health, and child health. And those were really the big problems of those times. But between 2018 and 2021-22, India implemented a set of reforms, and Sara referred to those as the Ayushman Bharat reforms. They're really a quartet of what we call schemes in India. So we have the primary health care, universal free access to primary health care by transforming existing peripheral health centers. Then we had an insurance program for secondary and tertiary, a little bit of which was spoken in the previous panel, a digital mission, and also an infrastructure mission. The digital mission and the infrastructure mission came after COVID. And together, the government, the policymakers said that this would be India's path to universal health coverage. Now, the reforms of the primary healthcare program were really unprecedented. Expanded HR, medicines, diagnostics. This was a system that was not used to having this level of resources pumped into it. So therefore, it is a complex intervention and takes time. Notwithstanding that, because I think it rested on a fairly robust implementation over the previous 2 decades on strong maternal and child health immunization systems, which we had got right because coverage improved substantially, maternal mortality declined, infant mortality. Adding on new service packages, adding on prevention, cancer prevention, it was very interesting to hear them say that. These are all challenges that we are yet to address. But I'd like to say that 7 years is a short time in a program's lifetime. It's just begun. There's a whole lot of new change paradigm mechanisms that have to be understood. We also have, I think, people think of primary healthcare and policymakers, practitioners, everyone, as being services delivered at that level of facility alone. For a functional primary healthcare system, you need to have a strong district health system. You cannot do primary healthcare without strong secondary healthcare and tertiary healthcare. You need strong health systems, whether they are procurement and supply chain, human resources for health, robust training systems. To get all of that in place is going to be an agenda that we are going to look at for at least the 2 decades from now. Now, if you ask me about the low-hanging fruit, yes, some of which we've done, but I think there are a few things that are actually need to happen for the trajectory to go a little beyond what it is today. And the first one is really this care continuum approach, which was envisaged in the PHC design, which is within an individual's lifetime from birth to death, how do they progress across the various life stages? So that's one care continuum. And the second is across levels of care. And in both of these, we need digital technology. Digital technology in India is there, and there are a lot of apps floating around, too many, if you ask me, portals, apps, everything that workers have to fill in. But that's really something that needs to be streamlined. So we look at both levels of care simultaneously. The second big challenge is quality of care. Traditionally in India, we've aimed at coverage and then come to quality a little later. But I think we've learned enough lessons now to say we can embark on quality at the same time as we aim to look at coverage. Because the soul and spirit of the comprehensive primary healthcare reforms, and I use the term soul and spirit very, very deliberately, was bringing services closer to people, the people-centered care component, compassion, dignity, safety. All of that can only come with greater attention to quality of care. So that's my second big challenge. My third, not challenge, but potential, if you will, is this thing about making a primary health center or these reforms address women's health issues. One of the achievements of the CPHC reforms, even in these 7 years, has been that more women are coming to the center, women beyond seeking care for pregnancy and delivery. Now that screening is available, such as it is, women are coming to the center. There are more medicines, so women are able to come there to get their medicine supplies. But how do we move women's health, the focus on women's health beyond pregnancy, delivery, to go on to chronic diseases, to gynecological conditions, to mental health? Great problem in India. We're not addressing that. But the fact that women are coming to these facilities and that we can do it, that's a third area I would say. And I'd like to say urban primary health care. India is now at 38% urbanization. In 2050, we'll be 50%. The challenge to urban primary healthcare, COVID threw that up. We were able to better manage COVID in rural areas because we had this really good infrastructure. By then, many of the health and wellness centers were operational. And that enabled us to actually deliver public health functions through these primary health centers. But in urban areas, none of that exists. We need to test models. We need to identify what human resources are needed, and engaging with the private sector, which, by the way, is very much work in progress. So I'm going to stop here, Sara, now, and
You've set a wide-ranging, but I think really important agenda for us. So I'm hearing sort of big 4 things that you're raising as the outstanding agenda. Sort of comprehensive and care and continuity of care, number 1, quality, number 2, women's health, number 3, and urban primary health care, where I think we're still struggling. Krishna, you've been working for several years now on a project that is trying to strengthen primary healthcare services. And I know that that's been thinking both about referral mechanisms between different levels of care, but also quality of care. And I wondered if you could speak a little bit about what you're finding to be some of the sort of promising interventions to address quality of care in primary healthcare.
Thank you, Sara, and also wanted to thank you for inviting me to this panel. And so I think the quality of care problem is a tricky problem. It's a very complex problem. And I think when...
Can you switch your mic on?
Yeah, okay. That's what Is this better?
Yeah.
Right. So it's a complex problem. And I won't try and answer how we can fix quality of care in India, but I'll highlight a few issues, some that Rajani's also brought up. So one is and I'm taking the approach of primary care, right? Because a lot of the studies that have assessed quality of care have focused on primary care, that is, outpatient consultations and such like. So if you take the position of how do you increase access to quality care at the population level, then one thing that we can't ignore is private providers and the private sector. We know that primary care, the majority of, say, first contact visits for primary care happen with the with the private sector. So they have to be part of this initiative in some way. Private sector itself is a very complex sector. You have formal providers, informal providers, and so forth, right? So it is a complex thing, but nonetheless, they have to be part of the inequality improvement solution. Now, I think at the hospital care level, a mechanism exists that can potentially give government leverage over improving quality of care, and that is this national insurance program that we have in India. But at the primary care level, nothing exists, right? And so that, to my mind, is also part of the complexity and the challenge. The second point I'd like to make is, if you look at all the study of interventions that have typically been done to improve quality of care, they're focused very much on the micro level, right? So, for example, training programs for health workers, or providing financial incentives to improve quality. And these have worked, but largely in a very marginal way. And what studies have also shown is that they haven't been very sustainable. So you give them training to health workers, and you see some improvement in quality of care, but after a while that tends to dissipate, right? And so my second point is that we need to look beyond interventions at the micro level, look at interventions that are more at the macro level or the meso level, and this was also something that was pointed out in a Lancet paper on improving quality health systems. And on that note, one of the studies, or rather pilot that we're implementing in Gujarat, focuses on trying to improve the environment within which primary healthcare workers work, through better communication with each other, through better problem-solving techniques and such like, engaging them more directly with the high-level management and so forth. And we'll see, what sort of effects that has. A third point I'd like to make is that the public sector has a very important role, I think, in improving overall quality of care. And studies, at least one study that comes to mind, has shown that states that where the public sector, so first of all, there's a lot of variation in the quality of care in the public sector. There's public primary healthcare centers across states in India. But what these studies have also demonstrated is that where you have good public quality of care, where there's better public quality of care, you have better private care, including better care by informal providers. So in a way, the public sector is sort of a standard setting for quality. And it's a thing that was surprising to me also. But that's what these studies show. So, and that is what government has leverage on, right? They can create better quality of care, at least they have the possible mechanism to do that in their own public sector. So I think the public sector is also an important force in improving quality. Finally, I'll also say that India's spending on primary healthcare is quite low. Studies show that we spend about $30 per capita. Sri Lanka spends 60, Thailand spends 120. So you can't expect a lot to come out of $30 per capita, right? Anyway, I'll stop there.
Thank you very much. Just to clarify, that's government spending.
Government spending, right.
Private out-of-pocket spending is much more significant. Yeah. Somesh, I heard a lot of conversation this afternoon, not necessarily in the health sessions, but about digital technologies, AI, quantum, which I have to admit I haven't found out what that is. So if someone would like to enlighten me later, that would be great. But you're currently in this role at JHPIEGO, which is sort of thinking about innovations in health. But you know the Indian healthcare system really well, and primary healthcare. What scope do you think there is for innovation to drive quality improvements, to address some of these challenges that we've been talking about? And what kind of technologies are you thinking would be helpful?
Thank you, Sara, and thank you for having me. So first, I don't do quantum at all. Me too. I've tried to, but I just can't get my head around. But I can answer your question. I can try to. So I think given, what we heard in the afternoon, that the talent pool that we have, the innovation ecosystem that we have, when what Rajani was talking about, the foundation that has been laid over the last 6-7 years through these 160,000 health and wellness centers, which is essentially strengthening of a layer of a primary healthcare system which was there, but it's really strengthening in a very transformative manner. I think digital technologies do have a major role in sometimes leapfrogging some of the system barriers that have been there. Digital technologies, the way I think of it for my simplicity of thinking is essentially three things for primary healthcare level. And it's actually more than that, but I'll try to break it down. For primary healthcare systems, these three sets of technologies include, one is the telehealth, right? Telehealth, India is implementing an e-Sanjeevani program, which is the government public telehealth program, where the difference is that this foundation stone of 160,000 community health workers, they are facilitating most of the telehealth consultations. So it's not necessarily only the clients or the patients are themselves talking to somebody in the clinic, in the hospital, but it's a facilitated consultation, which when the quality improves, it's still, as Rajani said, that, all of this is work in progress. It will take time. But as it improves, I think the facilitated teleconsultation in a context like India will go a long way in really amplifying or accelerating access. So you have a doctor at one end, you have the patient at one end, and then you have a community health officer who can take the vitals of that patient, facilitate that consultation, a quality consultation between a doctor in a district hospital or plus in a medical college and a patient who has, for example, just hypertension or something else. So telehealth is one important component that is now implemented at scale. And once the quality improves, it will really have a very good impact on access. If you add the second element is the digitization of the data systems. And that, I think, is another transformation that is going to happen. Rajani mentioned about the Ayushman Bharat digital mission. So it's a digital infrastructure being created where each patient or each client will have a unique ID number. Wherever he or she goes, that ID number will follow her. And then there is the connectedness of all primary healthcare centers and gradually the other health facilities, whether it's public and private, into that digital architecture that is being created. Now, if you think about it, again, this is all work in progress, but this patient will be followed can be followed through the continuum for a coordinated care. So and this is not happening today. So that's what can happen. Hopefully, it happens very soon because the building blocks are getting there. So that patient goes from a primary healthcare facility to a district hospital. The coordination of care is much more smoother, so that district hospital doctor can see what was the findings in the primary healthcare system or what lab investigations have been done close by. So that coordinated care to the the digitized data systems, the foundation stones are being laid. Is the second very important element of it. And the third one is the last mile or near point of care diagnostics that are coming to whether it's for infectious diseases like tuberculosis or for maternal newborn child health conditions. Simple things like sphygmanometer, digital sphygmanometer being there, or weighing machines for the mom and the baby. All of these are the last mile, but when the package comes together of all these important diagnostics of the major killers in India or the major disease burdens, it's really transformative. Now, these are three big types of technologies. The magic happens when these start coming together, sometimes in two or sometimes in three ways. When you have point of care technologies or diagnostics connected with your digital ecosystems, the digital data systems, then everybody, the lab information system starts to flow, and everybody gets, the doctors get the information. And all of this, Sarah, finally, these three things, when they come in together, the data systems start flowing in. You will have quality data at a large level to then, help powering of or leveraging the power of AI and machine learning to transform care, whether it is a population health level to predict, there is an outbreak coming or something, or not predict, but also, but at least say, when it is likely to come, as well as at an individual level, which woman is likely not to come for the fourth ANC, antenatal care visit, or which HIV person suffering from HIV is not likely to come for the ARV, or which TB patient is more likely to have complications. So these three technologies, when coming together, can have a lot of impact.
Thank you very much indeed, Somesh. I'm going to put you on the spot in a minute, Rajani, but I wanted to point out that there is a mic here. I can't see if there are other mics in the room, but if you would like to ask a question, please do come and stand behind the mic and we will start taking some questions in just a minute. I'm going to put you on the spot, Rajani, because I've heard you question how significant some of these digital technologies will be in terms of changing primary healthcare. Would you just care to elaborate on some of your thinking there, and what makes you slightly cynical? Skeptical, maybe on the cynical, yeah.
Actually, India is 35 states, 35 combination of states and union territories. The level of infrastructure, the level of information asymmetry, the literacy levels of our frontline workers are all major factors in making digital technology happen. I work a lot in the north of India. I see the potential for what Somesh says in the south and west of India. And there it's got to be tested and tried. And of course, I see a potential for digital technology. I mean, I have electronic health records, right? I believe that it should be there for every Indian citizen or anybody. But I think we have to recognize the gap at which many parts of the country, they have huge gaps. They have HR gaps. They have community health workers who were selected for just doing maternal child health referral. And now we're asking them to fill in community-based assessment checklists, enter data into this portal. And that's where I think we are moving too fast in some states, not building on what we have in some other states. I see the potential and it will happen. So I'm skeptical about it being tested in the north and the east of India today. A decade later, of course, it's possible there as well.
Thank you. That's a super helpful clarification. And I also appreciate the fact that you pointed out that we're talking about a huge and very diverse country, which I think, sometimes when we're talking about India, we forget that. I thought I had just released the poll results. I don't know, can anyone else see the poll results on their phone?
Yeah.
Yes. Oh, good. Okay. So we had asked you, and for those of you who are not playing with the app, which of the following pillars do you think will be most critical in driving access to quality primary healthcare in India? We have 25 responses at the moment. That's a poor response rate. As a researcher, I'm a little disappointed. But the lead is actually stronger governance and accountability, including community engagement, which we haven't actually talked about a whole lot, and we should talk about that. With 8 votes. The second one is actually strengthening frontline health workforce. The third one is making more effective engagement of the private sector, followed by digital technological innovation, and finally financial investment. Which is kind of interesting. I know Rajani beforehand said all of the above. So I think there's arguments for all of those. No one has lined up here, but does anyone like to ask a question? Can you get over there? Because otherwise I have to run around with the mic, I think. Anyone else like to ask a question, make a comment? Please keep it brief, but we would really welcome them. Yes, let's take the first 4. I think we have 4 people heading there straight away. If you guys can keep notes, then we can respond.
Can you hear me?
No.
Okay, so I'm from an organization called Vision Spring, and we work in India and all over the world. Our objective is to address impaired vision. I'm not talking about anything that requires surgical intervention. Cataract in India is about 35 million people, but the estimated number of people with impaired vision is 350 to 500 million Indians, and it grows every year because it's based on age, as you all know, and you all are doctors. So the question is, would the primary healthcare centers accommodate people who want to come in and get their eyes tested? Because we have a difficulty in a program. We've done this for 8 million people in India and provided, checked their eyes and provided them spectacles. The rate at which this problem is growing, can primary healthcare centers become a point where we can send people to get their eyes tested? They're a very simple process. So just
Thank you very much. I think we have the question about the role of health and wellness centers in eye health. Thank you. Next person.
Thank you for this discussion. I come from Bangalore and I am in a community health and family medicine and palliative care program. Just wanted to say about the digital technology. So one of the things that we do, like as ma'am was saying, that, you know, India is so many states and in so many linguistics. So what we are doing right now is medical ambient technology. They use NLP, that is natural language processing, where the health workers talk in whatever language. They just talk. This actually captures and puts it into medical things, and it gives the checkers. You don't have to actually take it or do anything. It's just by itself. It's in the, that is one part of it. Then we create LLMs, like instead of, so, but that LLM is not completely without, because traceability is a problem in normal LLMs, language models. But what we do is, there's a man in the middle. The expert is also in that. So what happens is that you can tell any symptoms. Suppose if I'm looking at cancer or just functional medicine about something.
You get to the question.
Yes. So I just wanted to know, like, even with the newer thing, I think one is, how do we use, like, your conventional thing of using these big data analytics to whatever now we use a simple like ChatGPT or LLMs? How do we see that in primary care, especially empowering the people in the grassroots? That's my question.
Thank you very much indeed.
Probably Roy Chaudhary from the University of North Carolina, Chapel Hill. My question is at the other end of the spectrum from LLMs. It's really about how successful or not the incorporation of Ayush workers in Ayushman Bharat has been, and also about the presence of Ayush packages within Ayushman Bharat.
Excellent. Interesting and important point. Nick?
Yeah.
Yes.
Hi, I'm Priya. I have experience of working with health system strengthening with Indian organizations. And my question comes with my personalized experience of working with the primary healthcare centers. That when we are talking about strengthening health workforce, are we also talking about their motivation and behavioral change component? Because majorly what they mostly complain of is that we are just getting overloaded with the work, with the digitization. So how do we cater to that factor?
Really important question as well. Thank you. Last but not least, and then I'll throw
I am Prakash, a student in Johns Hopkins, working for Sudha Setu in Chhattisgarh to reduce the healthcare disparity for marginal population who don't really have the permanent address. So how do we deal with them when there's telehealth? You talk about telehealth, you talk about digital IDs. People who don't really have their homes, they just live on trees, they just keep walking. So my question is for that.
Thank you very much indeed. So panel, you have quite a diverse set of questions there. Please don't feel like you need to touch, everyone needs to touch on each of them, but I'll start with Rajani and just respond to those which you have thoughts about and have interest in.
So I'll quickly address the ones on primary healthcare and vision. All PHCs, primary health centers, the lower level of facility is called the Health and Wellness Center or the Ayushman Arogya Mandir. The next level of care is a primary health center. And in the southern and the western states, there is screening, visual screening is done there. And it is possible if well planned. We're not even able to get over our cataract backlog. So if well planned, certainly vision screening primary health centers, that is the aim and the vision. And in some centers in India, and I just have to say this, outside the health and wellness centers, they painted the Snellen's chart and drawn a line in the earth. And so people can just stand there and say, can you see or not? And if not, then you go to the next level of care. But in a few centers, it's just a pilot, but it's a very easily scalable pilot. And the second question was about the Ayurveda system. So I think about 15 to 20% of the community health officers are from the Ayurveda practitioner. They are the only ones who've been allowed, not the other systems. 12,000 health and wellness centers are run by the Ministry of Traditional Medicine, which includes all the Ayurveda, homeopathy, etc. So they provide Ayurvedic packages, but not in the traditional health and wellness centers.
There was a lot there, Somesh, about digital and technologies, so maybe you'd like to take a crack at some of those.
Yeah, sure. So the question on LLMs, I think there are some demonstration or what we call pilots that are starting, and it's based on the national guidelines, and they're being brought together to help create LLMs using the Indian guidelines for just-in-time nudges or guidance to community health workers and even frontline workers. So that's something that is getting started. Multiple models are getting tested, and I see more and more of this happening. So LLMs are being utilized, and also a lot of NLPs, the natural language processing also getting utilized so that the worker doesn't have to type. So some of these models are getting tested as we speak, because and a lot of government agencies are themselves involved in this. On the migratory population and use of technology, see, while the question was asked to me on technology, so I had to answer on technology. But let me say very candidly, technology is not going to solve all the problems. It is just an accelerator or a lever, and the foundation stones have to be on the basics as Rajani talked about. So yes. Can technology help or leapfrog some of the barriers? Yes, but you have to have the context in mind as you are deploying the technology. So no, if there is, you have to have the basics of the social determinants of health, the home, the food, etc. And technology is no solution to those things. So you are right there. Those were the two questions.
Yes, perfect. Thank you. Krishna.
I'll just pick up on the Ayush question. I believe the Ayush doctors are very important in the primary healthcare space for another reason that Rajani mentioned, and that is, as many of you would know, there's a huge scarcity of MBBS doctors in rural areas of the country. Doctors just don't want to go and work in our villages. And often that position is taken up in a de facto way by these Ayush doctors. They don't replace the MBBS doctor, but they're kind of put together with them as a second medical officer and so forth. And so often they are the ones who are, running the place, they're the medical officer in charge and so forth. In studies that we did on Ayush doctors, and it was some time ago, what we found was a lot of the people who get into Ayush are people who couldn't get into medical school. So that's where they come into the Ayush system. Not everybody, but a good number. And they also study allopathic medicine along with their Ayush curriculum, right? And so I think this is a very interesting sort of situation where, anyway, I think they have a very important role in that respect. Right?
Thank you. We're nearing the end, but I wanted to use the chair's prerogative to follow up on the poll because, as I said, the dimension that most people thought was really important was around governance, accountability, and community engagement, which we haven't talked that much about. And I think I was really inspired by Yogendra Yadav's point about really trying to create a vision of modernity that comes from within and responds to the needs from within a community. So maybe to throw that to you guys as a question, in the context of primary healthcare in India, what do you see as the best strategies for engaging communities, for strengthening accountability, but in a way that doesn't overly burden people? We know that once you are involved in like sort of weekly village health committees or something like that, it's too much for people. So how do we get that input in a way that doesn't overwhelm people, but really does put their needs and their preferences at the center of primary healthcare?
No.
Well, I will anyway. India had this huge first set of reforms, we called them, from 2005, which was the National Rural Health Mission, then became the National Health Mission. We had a fairly substantive community health system framework set up. So the ASHAs the community health workers were part of it. We had village health sanitation nutrition committees. But actually where they worked really well, where local government was strong, India also has a very strong panchayat or local government system. Where the panchayat system is strong, where it comes together with robust village health committees and holding the ASHA as part of the village or the community structure is really where things happened well in the states of Orissa, Chhattisgarh, and Jharkhand, where all of these things came together, Maharashtra, Karnataka, Kerala, of course. So to me, community engagement, and I think we're losing a little bit of sight of that in implementing the health and wellness centers, because there are so many changes, you have the CHO, you have to get the medicines, you've got to get all the digital systems in place, even if they don't work in some places. So the community part of it has somehow gotten lost. And I think it's not too late. They've created a new structure called the Jan Arogya Samitis. But as Sara says, overburdening committees with this kind of thing is also tough. But the design has been so far of bringing the community and the health service providers at the front line together. And to me, that's an area we need to continue to work on, because with that comes accountability. We've had experience of that in the past. We've held Jan Sunwais, or I don't know how to translate that in English, but basically committees that hold providers accountable and said, I went to that facility and you were the one that charged me money for it. I've seen this happen in many parts of the country. And therefore, that's an area that we need to continue to work on and not lose sight of.
Somesh and Krishna, I'm going to give you the option of either answering that question, or I think Rajani did a great job at it, or another question is just takeaways for countries other than India. It's a big experiment going on in India. Do you have reflections about what other countries should be learning from this?
Okay, yeah, so I think a lot of learnings are going to come. So that's my first, as Rajani again said, we are just 6-7 years into actually this part of the journey. The journey of primary healthcare has been very long, but this part of the journey of the 4 elements, but a lot of learnings to come. One thing that I think I have learned, and I think there's learning to be made here, is when you invest in a frontline health worker, invest in training, extra training, as well as equip that worker with the diagnostics and drugs in a very systematic manner, and bring the entire primary health work team together. It's not one worker, but the team where you have a community health worker, you have the RCH worker, but the fulcrum of this entire population is one worker who is not only a provider, but also a manager of that primary healthcare delivery in that system. The potential is huge. So essentially making the point that if you have one enabled primary healthcare worker who's given that accountability and the power, it can work beautifully. I've seen this evolution and revolution happening in India, and there's a lot of learning there for multiple countries. If it can happen at such a scale in India, again, it's a journey in progress, but yeah, it's been a major learning for me. I didn't see that happening in this rapid pace that way it has happened.
Thank you. Krishna, it looks like you have the last word. You're standing between us and whatever's going on.
Okay.
I think, as Somesh said, I think the learnings have yet to come, but I see at least two areas where we could have important learnings coming from India that's relevant to other countries. One is in models of community engagement. I think India has, for a country at its level of development, has invested a lot in creating structures for community engagement. They may not work as we all aspire them to work and so forth, but they do exist. And so the potential of them working to improve engagement and so forth exists. And how that can be achieved, I think, would be a great learning for other countries. The second, I think, is with Ayush practitioners being involved in primary healthcare. And this is more relevant to countries in the region of South Asia because they also have these types of providers. But I think India has made important strides in formally incorporating them within the primary healthcare system, like I was talking about. And yeah.
Thank you very much indeed. I feel like it's been a fascinating discussion, but we've sort of begun to pull these threads, which we could go on talking about all evening. And I think that in particular, some of the connections that you have brought up in your comments between whether we're thinking about the Ayush and how they relate to the allopathic sort of healthcare workers, whether we're thinking about different levels of care, what we need to get to happen in terms of the workforce to make digital technology successful and vice versa. It feels to me like, as you're saying, there's a lot of learning going on right now and trying to capture this and distill it to feed it back into the reforms going forward, but also to make that learning available for other countries is really important. Thank you so much to the audience for sticking with us towards the bitter end. You all deserve a pat on the back, a clap, or maybe a clap for everyone on panel.